two techniques which are there, which is called primary parent artery preservation, okay, and one is parent artery occlusion. And then we have got standard aneurysm endovascular treatment. Then there is assistive devices, which is balloon assisted coiling, is called BAC, and the other one is called stent assisted coiling. Then the other things which are called neck bridging devices, PCONs, okay, FD. FDs are again divided into two groups, extrasaccular and intrasaccular. Extrasaccular, we will see in detail all those. Then we will talk a little bit about future what's happening and then different softwares, how it is going to be. So this is what when we started neurointervention. It was around 1986. You were not born during that time, I suppose. So during that time we have started. We are in the Sri Lanka. It was one of the pioneering institute where we have started the procedures. Just intracranial catheterization itself was a great challenge during that time. That means, so what we have to use is that now currently what we are doing is very fast. We are catheterizing the intracranial circulation, which is not at all possible. So what we are doing is that we are using this elastic catheters, which is folded inside, and then we raise the pressure by injecting saline inside one of those chambers. So the catheter will wriggle out and go into intracranial circulation. We go into it will go into ACR territory only because we have no guidance at all. Imaging was also very bad at that time because there was no digital subtractions available. Everything was film based. Film based, of course, we are running cine like examination was there, but after each examination we had to take the film for that home and process it and see it, and then only we can do. So that was a major deterrent factor. So all these things are changed up in 1989 where digital revolution has taken place. Computers have come into the medical field. Guide wire is in the order of 0.018 to 0.000. So these microcatheters were guided on the over the guide wire. The guide wire we can control the guide wire by torquing the guide wire so that we can reach the intracranial circulation in seconds. Interventions are only two types in the vascular thing. Either it is a blocking of the blood vessel, which is not useful for the body, which is bleeding or something like that, which need to be blocked. That is arresting that. That is called embolization. Second one is a blocked blood vessel, which is otherwise normal, which is circulating part of the system that is involved in circulation, which need to be blocked by because of emboli or trophus, whatever it is, so it just be removed. So these are only two. There's an opening technique called angioplasty and plus or minus stenting. The second one is called embolization, which is a bleeding. So what are the materials that is available you require to use? Material is microcatheter. We need of course guiding catheter and all, then microcatheter and then microwire and coils. The techniques I told you, there are only two types of technique. One is called parent artery preservation technique. That means you block the aneurysm, at the same time you will preserve the flow through the parent artery, so it will not block. So the second one is called the parent artery occlusion. So you occlude the aneurysm along with the parent artery, aneurysm and parent artery is occluded. In selected cases we can do. So it is much particularly useful in narrow neck aneurysm, that is called standard coiling. And then there is another one which is called wide neck aneurysm. We shall see in detail how we can use that. If you are satisfied, otherwise you can retrieve the coil and you can use a new coil depending on the size of the aneurysm. Here we see an example of a narrow neck aneurysm. How do we do it? We initially catheterize by means of a wire, and over the wire you advance microcatheter. On the microcatheter you put the coil inside like this, and then coil aneurysm finally removes. So you exclude the aneurysm from circulation. This is the detacher which is available, DDC detacher that is available. You can subsequently insert the coils and then fill the coil. This vessel which is going posteriorly. This is the anterior part. This is posterior part. What is the vessel which will go from ICA to backwards? PCOM. Hmm. Confidently say PCOM, posterior communicating artery, which joins the PCA. So this much part, this much only, or 1, 2, 3 centimeter only PCOM. Beyond that is called PCA. Okay. So this is same thing that you will see on vertebral artery injection. Vertebral artery injection, the finally the terminal part of vertebral artery will turn out into 4 branches, 2 PCS and 2 superior cerebellar. Okay. So of which this one part will join into this. So this is a natural communication between anterior and posterior circulation. So if the carotid is blocked, the vertebral artery will supply in a reverse direction into the carotid artery. That is how the normal circulation is maintained. So this segment from ophthalmic to PCOM, it is called posterior communicating segment. Communicating segment. The next vessel immediately after this posterior communicating is called next vessel called anterior choroidal. So aneurysm in and around the anterior choroidal we call choroidal aneurysm. Anterior choroidal aneurysm. That segment is between the carotid bifurcation. Then the next segment is the carotid termination. So there the vessels are originating that region only. Stress will come. There is the development of aneurysm. So there is carotid termination. Then it divides into 2 branches: ACA, which is going medially, MCA going laterally. Okay, so the MCA and ACA where it is dividing into 2 branches, the common aneurysm, and then the next one is MCA aneurysm. Here you can see the marker of the balloon, distal marker of the balloon and the proximal marker of the balloon. So once you inflate, you can see that there is a color change here. So insert and you insert the microcatheter here and put the coil here. So once you inflate and once you deflate, you can see that the entire aneurysm, this is on a blind rod pump. And once you deflate, this aneurysm is deflated balloon. On the aneurysm, if there is any projections into this, you can see that it becomes black in color. So you will be able to understand whether it is projecting back into the parent artery or not. If that is so, then we have to readjust the coils and then make sure that it is within the aneurysm. So that is how we do the balloon remodeling technique. This is called balloon remodeling. This is invented by a person called Professor Morey. Then we finish this coiling here and then go to the next aneurysm there on the top. Microcatheter is change its direction and then you go on to the next one. So you complete the procedure like this. So you got the posterior one, upper one. So here you can see this, understand. Here you have got the microcatheter. On the coil you have got a delivery wire has got a marker. So if you have got a bigger aneurysm, what will happen is that this coil will get overlapped on this. So that is why we wanted to know that the coils are delivered completely inside the aneurysm. When the coil mass comes inside, it is completely delivered or not. This can be understood if the marker is crossed from here. So that is how we need to know about this, the second microcatheter. So that's how we complete it. And then you have got exclusion of the aneurysm from circulation. You can see here PCOM aneurysm. This is clip coil software. This coil mass is there here as a different color, and this one PCOM, and then MCA here, ACA there. Okay, a major complication that can come in procedure, that is called intra-procedure rupture. It is equal to another subarachnoid hemorrhage. So if that is so, then we have to do, if you have got a balloon is there, then immediately within next second you can inflate the balloon, we can arrest the bleeding and continue coiling so that completely occlude the aneurysm. So that is the major advantage of using that. Whereas surgeons, when they do dissection or anything like that, intra-procedure rupture can come. If that is so, what they do is that they have to put the clip here, they have to put the clip here, just like trapping. That is how they control the aneurysm, control the bleeding. So as you gain experience, we can do procedures like this. very wide neck aneurysm. This is where MCA, correct. Medially it is ACA, laterally it is MCA. So this is MCA bifurcation aneurysm. So as we gain more and more experiences, you can see very wide neck aneurysm, where you can see even if you want to clip the aneurysm also, it is very difficult. See this main artery, this ACA, that is looking at the AP, we can understand that this is a common aneurysm, but we can see the origin of the aneurysm is like this, and the A1 is A2 is originating like this, second one is like this. So it is very difficult. If you put the coil here also, sometimes it will block this vessel. So if that is the case, then you have to use double balloon. It's called kissing balloon technique. So here you have to use one balloon like this here, second balloon like this, and then we can do the same principles. So this is how it is being done. You can see here one balloon here, second balloon there, microcatheter inside the aneurysm, and then put coils, balloons in place, aneurysm coiling. Different techniques are there. You can see completely excluding the aneurysm from circulation. So all these possibilities are there. Is clip coils of the preservation of vessels and excluding the aneurysm. Stent assisted coiling. So what is stent? So these are all stents. Stents, you know, typically we know stents are used in peripheral angioplasty and stenting, coronary angioplasty and stenting. So there the intention is to open the blood vessels with force, whereas in intracranial circulation using the management of aneurysm coiling, stent is not used for expanding or preventing the vessel from collapse. It is to make a wide neck aneurysm to a narrow neck aneurysm by putting a stent there. The purpose is totally different. Here, if you have got an aneurysm, this is wide neck aneurysm. This is like extremely wide neck aneurysm. You cannot manage with the balloon. By looking at the configuration itself, we know that, see, once you put the coil here and when the balloon deflates, every coil will come down, because it's physically impossible for aneurysm like this V-shaped aneurysm to keep the coils there inside. For example, where is the aneurysm? Very guess ophthalmic segment. Good. So, understood. Some principles are there. So here you have got the ophthalmic artery which is coming here. Okay. And then aneurysm which is fairly large aneurysm, and we have put the stent here. The stent, no, usually it is very tiny metals only, you will not be able to see. So distal end of the stent contains these markers. You can see 3, 4 markers here, and this is the proximal end. So here you can see this started from here. The stent is put like this and put like this, and through that one we catheterize inside and then produce coil. And stent assisted coiling can be done like this. Next. So this is how at the end you have stent assisted coiling coming like this. Next. So this is around 1 year follow-up. You can see that there is no other problem in the patient. Next. So the stent, once you have got a stent and if you have got a material available for you, then we can use different strategies and technique to use it. This is where, what is the aneurysm likely to be? MCA. My own representation. The one branch, you have got one division here, superior division and inferior division. You have got a large aneurysm here, large wide neck aneurysm. If that is so, then there are several techniques that you can do. First, you catheterize the aneurysm. Next one, we catheterize the inferior division. Then you deploy a stent. Next, stent like this from inferior division to M1, and then through the stent you go into upper one, and then deploy the stent next. So you have got stents like this. So this is called, how it will be looking like. So it will be looking like Y. It's called Y stenting. Y stenting and coiling. Okay. So it's possible aneurysm can be explored. Next, acom aneurysm. So this is left ICA, right ICA. A1, M1, okay, and then this is ACA, this is echo going to the opposite side, then this become like that. So in such cases, there is another special technique which is there next. Same thing, next you catheterize the aneurysm first with a microcatheter, next through the side of that one, next you put through the echo, go to the opposite A2, deploy a stent, next from the opposite side you come and go through the stents and put another stent like this, and then do the coiling through this and exclude the aneurysm from circulation. What is this? X, called extending and coiling. So likewise, any alphabet you name, you can take anything. It's on your own imagination and your own creativity. So you can understand, you can have extending. If you put it from here to here, here to here, and exclude the aneurysm from here, it's called H. So likewise, you can have T, you can have half T, you can have any number, anything, which depends upon that. Next, so next one is called MAFA. MAFA is maximal aneurysmal flow amplitude. So this is based on the flow velocity inside the aneurysm and the pre-arterial segment and post-arterial segment. If you do it before the putting a flow diverter and after putting a flow diverter, if you calculate the flow velocity ratio, then we can understand the changes that is taking place. So what is it? What is the clinical significance of this one? If the flow velocity is less than zero point 0.8, the aneurysm is likely that it will get thrombosed. If that is not so, then we can put additional material like coils inside. So we will get a guidance regarding whether coiling is required or not. So that is by using this technique which is called MAFA ratio find out. Master rotations of the scan can be taken place in the lab itself. We can find out what is the cerebral perfusion within the lab, so that team, when the patient stroke call comes in, you can activate here, you can reduce the time, okay, of bringing. There is something called concept like door to needle time. Door means door reaching onto the hospital, and where you are putting the needle in the groin, so the door to needle time can be reduced. Typically it will take around, when you reach in our casualty, it will take around 1 hour or 2 hour to reach into the place inside, and we can do the material like this. These devices are navigated depending on your control. Using that one, you can see it's like if you want to rotate your this thing, you have to have your hands bent. So whereas when you use this one, we can control the wire, control everything, and we can pre-rotate and take it into the appropriate vessels like this. Is in the process of development, whether you like it or not. Within another 10 years it will be like this. So it's again another major innovations which has been taken place. This all these things are quite possible. See, the oscillatory movement and all can be made like that, which is not possible with the human hand. So it's all quite possible. It's quite impressive, and then it will change. One of the major drawback of this one is that you will not get the tactile feedback. When you introduce into the body, you'll understand there is resistance or not. Whereas this will tell you there is resistance or not, but you will not be able to understand that tactile feedback is not there. But this is compensated by imaging advance.